Assalamu alaikum wa rahmatullahi wa barakatuh. I don't know whether Dr. Professor Abalkhail make my life more difficult or he almost give you the message at 1 o'clock. So I'm gonna to apologize from all the audience. They stayed late till 5 o'clock. I switch gear because my initial topic was a new paradigm of BBC management, but I'm gonna take another direction, how to personalize and use precision medicine to stratify medication for primary biliary cirrhosis. So I have nothing to disclose, so I reorganize my objective after Faisal Abalkhail presentation. So I'm going to start with the treatment goal. However, I'm going to concentrate in two items, which is personalizing the journey of medication or treatment for each patient, then how to stratify the risk and which way to personalize the patient. Probably the fourth one, which is already highlighted by Faisal Abalkhail, I'm going to skip. So if you see historical primary biliary cholangitis in the last almost 2.5 decades, started from the mid 18th century till like now, beginning of the 21st century, passes through different clinical and historical changes, like primary biliary cirrhosis, first described as a primary biliary cirrhosis in 1950. However, the name get changed in 2015 according to the European and ASLD guideline, just to remove a stigma and to actually define the case. Then liver biopsy exempted in 2018. Then we were still focusing in the biochemical response as of 2014. Obeticholic acid was the first approved second-line medication, but now we have a couple of approved medication in June and August of 2024, and all my colleagues highlighted already this one. So this is the BBC treatment goal. We have to prevent the poor clinical outcome from cirrhosis all the way to cancer and decompensation. However, this disease is started in the liver, but it has a lot of extra hepatic manifestation. If you see the patient, what's more important for him to see a decline of 0.1 or 0.2 or 2 point something of alkaline phosphatase, or to get improvement of itching. Itching is the first, and fatigue is the best. And that's why we are treating a biochemical. However, the patient concern is more of a clinical. And that's why we have to integrate and take the patient words and incorporate them in our management. And we know that each patient have a different presentation and different complaint. So we have to precisely personalize a management line, starting with establishing the diagnosis, because I will allude in my coming slide why it's make a difference when you establish a diagnosis from a stage patient A different from patient B or C, and that we go to the next step, which is a risk stratification. Because you have to remember, this disease, when we initially have only UDCA, now we have a multiple second-line medication that we can start from the beginning, but also tackle all the symptoms. And what way we monitor the response therapy, and we have to incorporate that for each patient. So once we start the diagnosis of the patient, once we start the diagnosis of the patient, we have to start the first-line therapy according to the risk stratification. Then we have to monitor this patient onward. So achieving our goal need putting a plan, short-term plan from risk stratification and beginning of treatment, setting a goal. And we also need an intermediate plan, which is addressing patient quality of life. Plus, we have to start early, not too late, to consider the second-line therapy, especially for this with high-risk patient. And a long-term plan should be for those who had a poor outcome, especially those with starting late and or they have to go to the transplantation. Risk stratification of one of the things that I want to allude in this presentation, because we have to classify our patient to a very low risk patient. That will implicate which line of therapy we have to start. Not only that, but also I'm pretty sure our senior colleague here, this patient will come to a clinic where you don't have, probably most of us, they don't have our own nurse to address his issue, from like fatigue score, like itching score. So we are treating his biochemical. However, what's the concerning of the patient is a clinical. And when he is in a low risk, i.e. asymptomatic with mild biochemical elevation, we have to put this patient in a follow-up, a longer follow-up compared to those with intermediate to high-risk patient where there is biochemical alkaline phosphatase and bilirubin increase plus symptomatology or association with other autoimmune liver disease. Those right categories where there is an established cirrhosis, especially established decompensation, we have to work hand to hand with the liver transplant surgeon and earlier referral, and to be careful of starting a second line therapy because they might get decompensation. So from here onward, we have to personalize and stratify each patient in which categories. First of all, is he a low risk or high risk? And if he is a high risk, is he a high risk with decompensation or a high risk of a presentation? And with this slide, I just to show you why it's important by handling the patient. There is a clear linear relationship between biochemical and patient outcome. I mean, if we can see the alkaline phosphatase and bilirubin mainly, especially those are the two markers of cholestasis, those who had or failed to achieve a decline in their alkaline phosphatase or bilirubin, they have a poorer outcome compared to those with an improvement. And not only that, also they have this marker started to be addressed as early as on to achieve what they call this an idea of deep response. Deep response means we have to achieve normalization instead of getting a decline with a percentage, like by different criteria. If you see Barcelona or Toronto criteria or the other criteria, they are talking about 6 months to 12 months. However, those patients, to achieve the target, we have to get a deep response, which is the ideal target to normalize in order to improve all his survival and long-term outcome. So this slide was already shown by Dr. Faisal. Initially, we have to start a first-line therapy, UDCA. Once he is in UDCA, according to the risk stratification and symptomatology, we have to treat his whatever, if there is a fatigue or pruritus, or if there is a Sjogren-like syndrome, or if there is an osteopenia, we have to treat them accordingly. But do not forget that this patient, according to this risk stratification, we have two things. First of all, early referral to appropriate department, and preferably if you have a nurse or people who is a good in assessing the score, especially for pruritus and fatigue, and those who is good in assessing his other, like involving the rheumatology and endocrinology as a multidisciplinary team approach. So staging and survey of the patient, those who had already established cirrhosis, do not forget to screen for varices and hepatocellular carcinoma. And this is a different scoring system that we are talking about. Do we have a pointer, ya Jama'ah? Okay.
You can point, Doctor.
So we have different criteria, Paris or Toronto criteria, and this is I think the battery is dying. So I think this is a different criteria that we are using once we start the therapy. And in this criteria, I put the slide to show you what I mean by the second slide. This slide, because we have to make sure that once we achieve a biochemical response, to avoid these things. Sometimes we achieve a good response as early as 1 month, and according to the study, they are following this 569 patient. They set a plan to see a lab at 1 month, 3 months, and 6 months, 12 months. They found a decline as early as 1 month, but then it get plateau. So in this patient, keeping the second line therapy introduction late, you are not going to get any gain. So you can start outside what the previous criteria that I'm talking about, which is turn to other criteria. You can start the second line therapy as early as the first or second or third month, especially those who's elderly at diagnosis or advanced fibrosis upon presentation. So, which patient will benefit from ALT normalization? There is no doubt those who had or sitted in the high-risk group, which is the elderly, the younger patient at diagnosis. I'm saying elderly, younger patient at diagnosis, or those with advanced fibrosis at the presentation. As you can see very clearly, those who normalize their alkaline phosphatase, they have a better survival and outcome compared to those who had not achieved this normalization. Then what to do? Once we have this biochemical addressing this issue, do we have to start continuing a follow-up, especially those who have a lot of, Center Saudi Arabia, they don't have the second line therapy. So we have to act promptly once you start the ortho, applying the criteria, stratifying your patient. Then we have to introduce the second line therapy as early as it's needed, especially those who is landed in the high-risk group. And the main aim of the second line therapy is not only improving the symptom and the quality of life, but also to reverse the consequence of this cholestatic problem, which is inflammation and fibrosis, and trying to normalize the alkaline phosphatase and bilirubin, which is the landmark or the markers of worst prognosis or worst outcome of this patient. We have initially UDCA, which is mechanismically, it increase the total bile acid balls that dilute more toxic hydrophobic bile acid. Then the second one, which is approved, which is the Ocaliva or OCA, and that was working in the reducing the bile acid synthesis and reducing enterohepatic circulation. And the third category, which is baragonist, which is also reducing the bile acid synthesis through the non-FXR pathway. We have now, there is a lot of flag about the OCA, which is the Ocaliva. So now we are talking about the Selidobar with elafibranor as, to start our patient with, especially those with significant pruritus, and they have a different mechanism, different response compared to the ODCA, like the Ocaliva had...
1 minute, doctor.
Okay. I'm just going to skip because Dr. Faisal alluded already in this trial, Dr. Umar, so make my life more easy, and I will go to my conclusion from this presentation, which is the new paradigm, which is the title of my lectures. The new paradigms start first-line therapy according to your risk stratification, probably UDCA. See the response as early as 1 month to 3 months. Do not delay the introduction of the second-line therapy. And once you have this facility in your center, you have to personalize your treatment, i.e. you can start even with the second-line therapy in substantive patient, especially with now fibroscan, MRI elastography, a lot of biotest, and the wishful plan or paradigm for this patient to achieve normal test, reverse the ductopenia and fibrosis, and normalizing the quality of life, which is, I don't know whether we are going to reach to it or not. So, in conclusion, the recent advance in the BBC is improving in the diagnostic tool, as we know that there is now so many blood and elastography or imaging modality to establish the diagnosis, and we have a new focus in the symptomatology and the management, including the itching and fatigue, and also reducing the burden in the patient and trying to normalize the alkaline phosphatase and bilirubin as early as possible. And also includes, we have to introduce the patient emphasis and outcome and feedback in our management. I think I'm going to conclude this slide. Thank you very much.